We'll move on to Dr. Adam Cuker. Adam is going to talk to us about COVID-19 and coagulopathy, a very relevant clinical topic for all of us. Take it away, Adam.
Thank you very much, Charu, and to you and the organizers for the honor of inviting me to present today and share the virtual podium with Dr. Fauci and the other esteemed speakers. And so, as Dr. Agarwal mentioned, I will be speaking about COVID-19 and coagulopathy, something that Dr. Fauci touched on in his presentation. And here is the outline for my talk. I will briefly discuss some of the clinical thrombotic manifestations we see with COVID-19, briefly review pathophysiology, and spend a bit more time talking about the incidence and prevention of venous thromboembolism in patients with COVID-19. So let's begin with clinical manifestations. So the thrombotic manifestations of COVID-19 are actually quite diverse. Most commonly, we see lower extremity deep vein thrombosis and pulmonary embolism. In patients in the intensive care unit who are hooked up to circuits such as renal replacement therapy or extracorporeal membrane oxygenation, we see very high rates of extracorporeal circuit occlusion. Autopsy studies show a high incidence of microvascular thrombosis, particularly in the lungs, but also to a lesser degree in the kidneys and skin. Not only can thrombi affect the venous and microvascular circulation, arterial thromboembolic events have been reported, including acute ischemic strokes, as you see here. And then many of you are familiar with this mysterious condition called COVID toe syndrome, where patients present with ischemic digits, often during the convalescent phase of the infection. So a number of diverse thrombotic manifestations with COVID-19, but for the purposes of my presentation tonight, I will be focusing on the most common thrombotic manifestations, venous thromboembolism, which comprises DVT and pulmonary embolism. So let's move on to pathophysiology. When we in the coagulation world think about the pathophysiology of thrombosis, we always come back to this man, Rudolf Virchow, a 19th century German pathologist, who postulated that thrombosis occurs because of one of three factors: circulatory stasis, an intrinsic hypercoagulable state, or endothelial injury. And we call that Virchow's triad. And so I would submit to you that while we still have a lot to learn about the mechanism of thrombosis in COVID-19, it's likely that all 3 points of Virchow's triad are at play. So let's start with circulatory stasis. The highest rates of thrombosis are seen in patients in the intensive care units who are often profoundly immobilized. These are patients on ventilators, on sedative and paralytic medications who are not moving for weeks. The sickest patients also have markers of hypercoagulation. They have often very marked elevation in clotting factors like factor VIII and fibrinogen, and very elevated levels of neutrophil extracellular traps, which are elaborated by activated neutrophils and are prothrombotic and potentially make a link between the profound inflammation we see in this disorder and the propensity for thrombosis. And then finally, endothelial injury. Many of the patients in the intensive care unit in particular have intravascular access devices, such as central venous catheters, and are at risk of developing thrombosis at those insertion sites. But we also see a really unique feature of COVID-19, endotheliitis, inflammation or profound injury to the endothelium, which may be due to either direct viral invasion of endothelial cells or injury to the endothelium secondary to the inflammatory response. So it's likely that all 3 of these points on Virchow's triad contribute to the prothrombotic phenotype of COVID-19. So incidence. Well, I'm often asked, what are the risk factors for COVID-19 associated venous thromboembolism? And many of those still need to be worked out, but I think that there's one clear risk factor that trumps the rest, and that is the severity of illness. The sicker the patient is, the higher the risk of venous thromboembolism. And so here's a model to illustrate this point. The population of patients at the very highest risk are patients who have critical illness in COVID-19, the ones we typically find in the intensive care unit. Second on the list are patients who are sick enough to be admitted to the hospital wards, what we call patients with acute illness. We know that when patients are discharged from the hospital, non-COVID-19 patients, they go home with an increased risk of thrombosis for the next 30 to 42 days. And so a third subgroup to watch is patients with COVID-19 who are being discharged from the hospital. And then finally, what about the thrombotic risk in non-hospitalized patients infected with SARS-CoV-2? So this figure is not meant to imply a linear relationship in VTE risk among these different subgroups, but simply to show that there is a clear and direct relationship between severity of illness and risk of venous thromboembolism. And I want to take you through the incidence numbers that we have for each of these four groups. So let's start with patients with critical illness. This is a forest plot from a recently published meta-analysis of 7 observational studies of patients with COVID-19 in the ICU. These patients, almost all of them, were receiving prophylactic intensity anticoagulation. And despite that, the incidence of venous thromboembolism was 24%, with a 95% confidence interval of 16 to 35. So that's pretty high. But we know that critical illness itself is a risk factor for venous thromboembolism. So is the risk greater in critically ill patients with COVID-19 than in their critically ill non-COVID-19 counterparts? And so the best available evidence we have would suggest the answer is yes. We know from meta-analyses of high-quality clinical trials that the incidence of breakthrough venous thromboembolism in critically ill non-COVID-19 patients, despite the use of prophylactic anticoagulation, is about 6%. And as I told you, the incidence we found in COVID-19 patients is 24%. So if you just look at the numbers, you say, boy, it looks like COVID-19 patients with critical illness have a several-fold higher risk of VTE than their non-COVID-19 counterparts. And that may be true, but we need to be careful in interpreting these data because the COVID-19 results come from observational studies, many of which are low quality and subject to risk of bias. So we need to take these data with a grain of salt before drawing firm conclusions. What about the risk of VTE in patients with COVID-19 and acute illness, the kind of patients that we would typically find on general wards? Well, here is a forest plot from the same meta-analysis, 4 studies that showed despite the use of prophylactic intensity anticoagulation, a risk of VTE of 9% with a 95% confidence interval of 3 to 22%. So how does that compare to acutely ill patients without COVID-19? Well, here are the data. So we know, again, from meta-analyses of high-quality clinical trials, that acutely ill non-COVID-19 patients have an incidence of VT of about 0.7%, despite the use of prophylactic intensity anticoagulation, much lower than the 9% observed in patients with COVID-19. But again, we need to be careful about drawing firm conclusions because of the low quality evidence that we have in COVID-19 thus far. So when patients with acute medical illness are discharged from the hospital, we know that they remain at increased risk of venous thromboembolism for at least 30 to 42 days after discharge. Is that true in patients with COVID-19 as well? Well, we now have 3 studies that have been reported that shed light on this question. The first is a study of 102 patients from Belgium, only 8% of whom were discharged on prophylactic anticoagulation. And of these, only 1 patient was diagnosed with DVT in the follow-up period. And I should mention this is a prospective study where all of the patients are undergoing screening ultrasounds of their legs at 42 days following discharge. And so this one event happened to be a silent DVT that was picked up on ultrasound. There were no patients that developed symptomatic VTE. Another study just published, 163 patients from Boston, only 8% of whom were treated with anticoagulation upon discharge, and only one of these patients, 0.6%, developed VTE in the 30-day follow-up period. And then lastly, a larger study, almost 1,900 patients from the United Kingdom, none of whom were discharged on prophylactic anticoagulation, and only 9 or 0.5% of these patients developed venous thromboembolism in the 6 weeks after discharge. So I think these data are quite reassuring that despite the infrequent use of post-discharge anticoagulation, the rate of VTE after discharge appears to be quite low. So here's a question I get asked a lot. What about the risk of venous thromboembolism in non-hospitalized patients? These might be asymptomatic individuals or individuals who are sick but not sick enough to warrant admission to the hospital. Are they at increased risk? Well, this space is intentionally left blank because we have no evidence on these patients right now. There have been, as some of you may recall, dramatic reports in the lay press of otherwise healthy patients presenting with stroke, for example, in the setting of COVID-19, or fatal pulmonary embolism in the setting of COVID-19. But although these cases get a lot of attention in the press, it is likely that they are extremely rare. Again, this is the group of patients of the 4 that I've presented that have the lowest severity of illness and are likely, similarly, to have the lowest incidence of VTE. So, as I've mentioned, there appears to be, based on the best available evidence we have, a high incidence of venous thromboembolism and acutely and critically ill patients with COVID-19. What can we do to reduce those rates? Well, there are a number of medical organizations that have issued guidance statements. Dr. Fauci actually mentioned the NIH guidance statement in particular. And this table summarizes the recommendations from these organizations. So if we look at acutely ill patients, sorts of patients we find on the wards, there is consensus among the guidance, among the organizations, that these patients should be treated with prophylactic intensity anticoagulation. Among critically ill patients, where the rate of VTE appears to be higher, some organizations recommend prophylactic intensity anticoagulation, while others suggest consideration of a higher dose, intermediate intensity anticoagulation. And then most of the societies suggest against the routine use of post-discharge anticoagulation. So what do I do? Well, in patients who are acutely ill on the wards, I recommend as the standard of care prophylactic intensity anticoagulation. Because of the low rates of post-discharge VTE that we saw, I suggest against the routine use of post-discharge anticoagulation, although certainly it could be considered in patients with strong risk factors, for example, a prior history of venous thromboembolism. And then the hardest group are the patients with critical illness, because they, of course, have the highest risk of clotting, but also the highest risk of anticoagulant-related bleeding. And so our approach at Penn has been, if these patients are judged to be at low bleeding risk, we suggest intermediate intensity anticoagulation. Whereas if they are judged to be at high bleeding risk, we suggest prophylactic intensity anticoagulation. But of course, these are just expert-based recommendations. What we desperately need are clinical trials. And I'm happy to say that if you go on clinicaltrials.gov, you will see this list of no less than 13 clinical trials, all actively recruiting, that are comparing different intensities of anticoagulation to prevent venous thromboembolism in critically ill and acutely ill patients with COVID-19. So we anxiously await those results. I think another important point to make, and I believe this was touched on in Dr. Fauci's presentation as well, is that anticoagulation may not be the only way or even the most effective way to reduce thrombosis in these patients. We call this thrombosis of COVID-19 immunothrombosis, because part of the pathophysiology, as we talked about, is the inflammation of endothelial cells. And so it may be that drugs that directly counteract that inflammation, or the source of that inflammation, could be effective at reducing thrombosis. Drugs like corticosteroids, antiviral agents, anti-cytokine drugs, anti-complement therapy. And so all of these different classes of drugs are being tested in COVID-19, and we in the hematology community are urging the investigators to include thrombosis as one of the outcomes they collect. So to conclude, a few take-home points. First, thrombotic manifestations of COVID-19 are diverse and include most commonly venous thromboembolism, but also arterial and microvascular thrombosis. Potential mechanisms of thrombosis include immobilization, hypercoagulability, and endothelial injury. The baseline risk of COVID-19 associated venous thromboembolism increases with illness severity. And the best available evidence we have suggests that critically ill and acutely ill COVID-19 patients may have a several-fold greater risk of VTE than their critically ill and acutely ill counterparts without COVID-19. But again, the evidence in COVID-19 is of low quality and we need better, higher quality data. The risk of VTE in COVID-19 patients after hospital discharge appears to be quite low, probably less than 1%. But hospitalized patients who are at greater risk should in general be treated with anticoagulation to reduce the risk of VTE, and clinical trials to determine the optimal intensity of anticoagulation are currently in progress. And again, I'd like to thank the organizers very much for allowing me to speak and the audience for your attention.